team, Dr. Suresh Mahendran, Dr. Hemi Patel, Dr. Christoph Wink, and Dr. Kate Dimbleby and I thank you for the opportunity of presenting to you the epidemiological trends of head and neck cancer in the Northern Territory 2009 to 2016. I'm speaking to you from the traditional lands of the Laragia people. I pay my respect to elders, past, present, and emerging. Special acknowledgement to Dr. Hemi Patel and Dr. Minnie Jacobs. Ethics approval was granted and maintained. We're awaiting maxillofacial department authorization for Subsite data use, no conflicts of interest, and non-fouling. For those who haven't had the privilege of coming to the territory, allow me to tell you it's a beautiful and large, sparsely populated territory with 246,500 population, of which a third are indigenous. Previous attempts have been done for describing the complexity of the epidemiology of head and neck cancer in the territory. So before we go into topic, please give me a couple of minutes and think, what do you think about head and neck cancer in the territory? We have done proper statistical analysis. We've started with 618 records, of which we remove 86 duplicates, then we remove hematological lip and skin cancers, and we finish with 405 cases. Of the 405 cases, the mean age of presentation was 62.9 with a male predominance. The age standardized incidence was 22.1 new cases per 100,000 population. This implies that our population has 4 times more likely a possibility of having head and neck cancer. The incidence in indigenous population was 24.8 per 100,000 versus non-indigenous 20.9 per 100,000, which is clearly less than previously stated. Now that we have explored the overall data, let's do into subsites. The model subsite is oropharynx with 150 cases. The overall 5-year survival was 43%, which is behind the national standard, 64.7% included lip. No statistical significance was found while calculating disease-specific survival. This slide describes the survival rates by subsite, being the highest survival in salivary glands and the lowest in sinonasal malignancies. In general, all our subsites are behind the national reported. Our study showed a lower survival among indigenous population, with 23.6% comparing with non-indigenous of 47.9%. This is statistically significant. In our sample, 90% were smokers with a mean of 39.9 pack years and 70% with a positive alcohol abuse history. Note that in Australia by 2019, only 11% of the population were smokers. Rurality has shown to be another contributing factor, with worse survival in rural and remote areas comparing with metropolitan areas. This slide shows that from the dataset analysis we are able to identify incidence hotspots, which could be of benefit from intervention strategies in the future. In our cohort, P16 data is completing 73%, of which 55% were P16 negative and 18% P16 positive. So yes, our P16 negative rates are 3 times higher than P16 positive. This slide shows the proportion of P16 status by subsite. See a predominance of P16 negative, which is represented in red. 60% of our patients presented late in stage 3 and 4. Moreover, indigenous population have 2.7 times higher possibility to present in a late stage. Our comorbidities were assessed using the Charlson's comorbidity score, which has been validated for its use in head and neck cancers, allowing to identify the severity of comorbidities, survival prognosis, and potential complications. Our mean Charlson's comorbidity index was 7.9, meaning severe grade of comorbidities, and there was no statistical significance between indigenous and non-indigenous. Regarding treatment, 36% of our population went to palliative intent at presentation. This slide is an exercise of the overall survival, removing that 36% who went into palliative intent, making our data more in keeping with published literature. This trivariant histogram shows that treatment modality by stage, P16 and vital status. Of note, more stage 1, 2, and 3 patients who had surgery alone and surgery and radiotherapy or trimodality management are alive, in comparison with worse outcomes of patients who received chemoradiotherapy or radiotherapy alone. You may remember those 36% of patients who deemed palliative at presentation. Of those who had curative intent, 61% had no recurrences. 39 that did, local recurrence was the most common, followed by regional and distal. This is a complex but very useful slide with multivariate histogram that demonstrate that surgery and surgery with radiotherapy for early stage disease and trimodality for later stage disease may confer less local and regional recurrences in all but hypopharynx. So, do you remember those ideas you may have about head and neck cancer in the Northern Territory? Overall, do we have a higher incidence? Yes, we do. Do we have late presentation? Yes. Do rural patients do worse? Yes. Indigenous patients do worse? Yes. Indigenous patients have more comorbidities than non-indigenous? That's actually not true, and we have shown it with our Charlson's comorbidity index calculation. Are our survivals comparable to other centers? No, they are not. Do we have a majority of P16 disease positive? No, the vast majority are P16 negative. We can deduce that early identification is key, and we need to understand that comparing our population with interstate and overseas population is a misinterpretation, as the Northern Territory population is unique. We need to be able to identify and discuss our subsite outcomes and treatment modality, and we need to identify the pathology in an early stage, understanding particularities and complexities of our unique population. Hence, culturally safe practice is absolutely fundamental. So why do our patients do badly? 3 main factors: late and advanced presentation with P16 negative disease, remoteness, and still a deficient culturally safe practice. So what's the future? We have the challenge of early identification, so we need to think about early detection, engaging with indigenous communities, better education, empathy, and culturally safe care. Is there a tool that we can use as screening? If we do detect early, can we offer comprehensive treatment? Where shall we treat this patient? So a lot of work still needs to be done. Our aim in this study was to confirm or dispel the presumptions of head and neck cancer in the Northern Territory. I hope this will be the first of a lot of more research still needed to be done in order to provide patient-centered and culturally appropriate care in the